My name is Shirley Mertz, and I have been living with metastatic breast cancer for 11 years. Thank you, and thank all the doctors. On behalf of the Metastatic Breast Cancer Network, I welcome you to our 8th annual Metastatic Breast Cancer Conference, organized in cooperation with the University of North Carolina Lineberger Comprehensive Cancer Center. MBCN's annual conference is our major educational outreach to patients, and the conference is organized by volunteers who are also metastatic patients. This past year, MBCN lost 2 of its board members, Kathy Corsi-Bowes of Georgia and Joni Gudeman of Illinois. For years, they contributed significantly to our work and made a difference in the lives of other patients, and we just want to honor them and say that we miss them. Today's conference was planned by a dedicated team, and I want to introduce them to you. If they would please stand, I think they're right down here, and be recognized. Conference Chair Deb Tincher from Ohio. This is her 5th conference that she's organized. Ginny Nachmus, Vice President and Treasurer, Ginny. And Ginny did a great job last night. And Catherine O'Brien, Secretary and Publicity Chair from Illinois. We are here in Chapel Hill today because of the commitment of the University of North Carolina oncologists, radiologists, surgeons, and other healthcare professionals who agreed generously to give their time and expertise today and tomorrow. We are very grateful to every one of them. In particular, I wish to acknowledge Dr. Lisa Carey, Medical Director of the UNC Breast Center, and Dr. Carrie Anders, Associate Professor of Medicine, who initially agreed that UNC would partner with MBCN for the conference. Dr. Anders and Jean Sellers, UNC Cancer Administrative Director of the UNC Cancer Network, worked for many months with us and selected speakers. I would like to now introduce Dr. Carrie Anders, who wants to share a personal greeting. Dr. Anders.
Well, good morning, everyone. So as a North Carolina native, I just wanted to extend a very warm welcome to a beautiful fall morning in North Carolina, and also want to thank everyone who's traveled from within North Carolina and outside North Carolina, and I even understand from Europe, to be here with us today. We're so honored to have been selected as the host institution for the 8th conference this year. And in actuality, as Shirley said, the planning has been going on for many, many months. She introduced herself to me at the San Antonio Breast Cancer Symposium Conference back in December. And we've been so honored to work with her and her team for the planning today. And who would have known we'd be standing here almost 9 months later with such a full agenda on the progresses being made in metastatic breast cancer. We've carefully selected an agenda, an array of University of North Carolina speakers to cover a wide range of topics that we hope will speak to everyone in the room. So I hope you enjoy each of the sessions. And I also wanted to extend a special thanks to Shirley and to Deb and everyone on her team, and particularly Jean Sellers here at the University of North Carolina, for their meticulous and tireless planning over the course of the past 9 months. And also to Dr. Zagar, who helped us with the local therapy planning of this session and sat through many meetings and phone calls to bring us here today. So thank you all so much, a warm, warm welcome, and enjoy your day. Thank you.
Organizing a conference takes both human and financial resources, and MBCN wants to acknowledge the advocacy and cancer organizations that donated funds to make this conference possible. First, MBCN thanks the UNC Comprehensive Cancer Center for their financial contribution to the conference. A generous grant from Susan G. Coleman ensured that we could offer travel grants to those who needed them. The Avon Foundation for Women also contributed funds to make attendee travel possible. Share Cancer Support of New York helped make last evening's networking reception possible. And we also are very grateful to the pharmaceutical companies whose ongoing research results in treatments for us in the clinic, but who also saw fit to help us with the support of the conference. So I wish to publicly thank and offer my sincere appreciation to Genentech, Novartis, Amgen, AstraZeneca, Eisai, and Pfizer. Thank you all. Deb Tincher would now like to come forward and just give you some basic logistics of the conference. And Deb is waiting for 2 twin grandchildren to be born any moment, but not today or tomorrow.
Good morning. All of our team worked very hard for this day. We've been looking forward to it since January, and I am so happy to see so many smiling faces. I was a kindergarten teacher for 30 years, and this is exactly what I call a teachable moment. You will have so much to learn today. We have esteemed speakers. We have the most ambitious agenda we've ever had. We've never had 5 breakouts at one time. We've never had 2 doctors speak on the same subject at the same time. So we are truly happy for the University of North Carolina being so welcoming and going way overboard to put this together today. I think there are probably some of you out there who this may be your first conference. A few people. Oh my goodness. Welcome, welcome. I think there may be some people out there who, until they came here, did not have a friend who had metastatic disease that you could talk to and you could share your experiences with. Is there anyone? A few people like that. Well, look around you. Look at all of these people that you can gain knowledge from, and most of all, support. So I hope this weekend is a great opportunity for you to network and make those friends, because nobody understands how we walk in our shoes. Nobody understands the emotional roller coaster that we ride on every day. And to have a good friend share that with you is invaluable. So I hope you make a lot of friends today. Okay, now for the nuts and bolts. We have in your folder, we have index cards. And this is how you are going to ask questions of the speakers. The speakers are going to talk for approximately half of their presentation time, and they will use the last half for questions. So what we're going to ask you to do is write your question on the card and pass your cards out towards the aisles, and people will be coming up and down the aisles to collect the cards, and then we will have people ask the questions of the speakers, and we'll try to get as many in as we can. I want to say that we did include a floor plan, and it may not be too clear, so I just want to say that we're in Grumman Auditorium. To go to Windflower and Bellflower, you're going to go out this door and you're going to go all the way to the last rooms on the right. And you'll be able to see that on your floor plan. It's a little hard to read. If your breakout is in Azalea or Mountain Laurel, you're going to leave here and go all the way down this way. Oh, this is your right. Right, this is your left. It's my, my left. And those are the last 2 rooms. So if you have any trouble, there will be a lot of volunteers out in the hall to help you find those breakouts. and we're going to try to stay on time as much as we can today. So we kind of want to be prompt with everything. And the last thing I would like to say, oh no, one more. If you are a grant person, if you received a travel grant, you need to visit the reservation table because you have a special evaluation to fill out, and you have a reimbursement form to fill out and mail to us, so don't forget those. And it is so, so, so important to us for you to fill out our evaluation form. I kind of think it's easier to do it during the day, but, you know, anytime you have to jot down some specific things for us, every board member reads every evaluation sheet, and we truly use these to make the next year's conference better. So we are very, very interested in your comments about the conference itself, presentations, anything like that. And so if you're leaving today, there will be a box out at the registration desk. And if you're leaving tomorrow, we'll collect those tomorrow. And I hope all of you have a day to remember. Thank you.
Okay, we are on time. We're kind of now going to go into the plenary. And I'm going to begin by first focusing attention on the patients in the audience. As Deb said, if this is your first Metastatic Breast Cancer Network conference, and there were so many hands that said it is, you will realize as you look around the room that we patients share a common bond, and we understand the enormous daily challenges that we each face. So I'd like to take a quick survey to get an idea of our experiences. And while I do this, I know we're not owls, but if you could kind of turn around and look at what happens in the next couple minutes, it might be very inspiring. So here's my question. Now that you've got comfortable, if you are living with a metastatic breast cancer diagnosis, would you please stand? All right. If you have been living with the disease for 1 year or more, would you remain standing? If you have been living with the disease 2 years or more, would you remain standing? 3 years or more? All right, all of you who are standing right now, you've defied the survival statistics, okay? If you've been living with the disease 4 years or more, remain standing. 5 years or more? 6 years or more? 7 or more? All right. 8 years or more? Bless you. 9 years or more? 10 years or more? All right. Now wait. I'm just going to go quickly around the room. Would you shout out how many years you've been living with the disease? The lady in the purple. 12.5. Yes. Okay. Susan Raft, how long? Thank you. Next, yes. 16. And you, please? 10.5. Yay. And your wife, sir? 14 years. God bless her. 14 years. And Bob in the back? 12 years. 12 years. Thank you. That is just amazing. So I think that is so inspiring for all of us to realize. Okay, for those of us who are patients, I am confident that you remember the exact place and day when you were told you had metastatic breast cancer. Once you received that diagnosis, talking to family, friends, and people at home or at work presented many challenges. Should I tell the people I know? What should I say? And how much should I share? If you decided to share that you had metastatic breast cancer with someone, I bet, based on my own experiences, that you've heard some surprising and dumb comments. Let's take a moment to view a video created by our own Catherine O'Brien of MBCN. The video is based on the experiences of real patients who talked and shared about their conversations with family and friends with Catherine, and she developed this video. It's very short. It's called Dumb Stuff. So could we have the Dumb Stuff video?
Getting to know you, getting to know all about you, getting to like you, getting to hope you like me, getting to know you, putting it my way, but nicely. You are precisely my cup of tea. Getting to know you, getting to feel free and easy. When I am with you, getting to know what to say. Haven't you noticed, suddenly I'm bright and breezy because of all the beautiful and new things I'm learning about you day by day. Getting to feel free and easy. Getting to know what to say. Haven't you noticed, suddenly I'm bright and breezy because of all the beautiful and new things I'm learning about you. 1, 2, 3.
There's a dark and a troubled side of life, but there's a bright and a sunny side too. Though we meet with the darkness and strife, the sunny side we also may view. Keep on the sunny side, always on the sunny side. Keep on the sunny side of life. It will help us every day, it will brighten all the way, if we keep on the sunny side of life. Though the storm in its fury broke today, crushing hopes that we cherish so dear, clouds and storms will in time pass away, the sun again will shine bright and clear. Keep on the sunny side, always on the sunny side. Keep on the sunny side of life. It will help us every day, it will brighten all the way, if we keep on the sunny side of life.
Is that not funny, and is she not creative, right? Thank you, Catherine. You know, it is a funny video, and I have heard that sometimes laughter can start a serious conversation. It was clear that the questions and comments in the video indicate that people understand very little about metastatic breast cancer. Recently, Pfizer, a pharmaceutical company, decided to assess public knowledge and understanding of metastatic breast cancer. And to do this, Pfizer commissioned a well-designed survey of almost 2,100 people in the United States last April of 2014. The demographics of those surveyed included both men and women, ages from 18 to 65, all representative of socioeconomic, geographic, and educational groups in society. They were asked a series of questions about what they knew about metastatic breast cancer. The full results of this survey will be released in October. However, Pfizer has shared a preview of some of its results that I can share with you. The preview revealed that 60% of the people surveyed report that they know little or nothing about metastatic breast cancer. 72% believe that metastatic breast cancer is curable if caught early. 50% believe that patients experience progression of breast cancer because they didn't take the right medicines or take preventive measures. Clearly, there is a large gap between our reality as metastatic patients and the public's understanding of our disease. And this gap exists in spite of all the talk about breast cancer in our society. Perhaps more accurately, we should say that public messaging about the cure and survivorship is so pervasive that people think those messages are the whole story about breast cancer. In fact, these messages about care, a cure, and survivorship lead the public to believe that we who have metastatic disease failed to take care of ourselves or take treatment. Those are false conclusions, and I never want you to take those personally. Should this knowledge and information gap about the full story of breast cancer matter to us? Absolutely. To get others to support our needs, the public must first understand how different and unique metastatic breast cancer is from early stage disease, that there is no cure for stage 4, that our treatments never end, and that our anxiety about the future is always with us. Stage 4 breast cancer is rarely talked about in the media and magazines during Breast Cancer Awareness Month. I just saw the recent October issue of a major woman's magazine. It came to my house. It had about 8 pages about breast cancer, and the words metastatic or stage 4 were absent. If the complete story of breast cancer were made known to the public, more research for metastatic disease could be dedicated to help us live longer. We have the kind of cancer that shortens lives. The public might learn that we need better information to help us make treatment decisions, and that we need supportive services to help us cope. Some of you who are new to this community of metastatic disease may be saying, well, wait, why should this matter to me now? I've been told that I have an incurable disease. Well, I want to share something with you. While our disease may not be curable yet, more research, focused research, has the potential to turn metastatic breast cancer into a truly chronic disease, or I should say chronic diseases, for patients so that we could live longer with the disease. In the 1980s, it was the actions of individuals and organizations of HIV/AIDS patients who demanded focused research that turned HIV/AIDS from an immediate death sentence into a chronic disease. Today, HIV/AIDS patients with access to care can live 20 to 30 years beyond their diagnosis. If greater percentage of breast cancer research funds could go to our stage 4 disease, I believe that could be our future. So I challenge you today to take action. You were given a t-shirt today. Our mantra must be, stage 4 needs more. We need to speak honestly and openly about our disease. Like those in the HIV/AIDS movement, we must be visible. We must not hide. We must not be embarrassed or too modest to demand more for stage 4. We are worthy of attention, and we deserve better outcomes in the clinic. So quickly, how do we do this? We must use our voice, to tell our story. Stories catch people's attention and teach others what they need to know. Think of the Bible. It is how people learn and what they remember. Stories help people figure out what is good and right to do. And through stories, people are moved to think about their own future and the future of society. When you tell someone else that you were treated for early stage breast cancer and that now, years later, you have metastatic breast cancer, you are teaching others that we do not know why breast cancer returns as metastatic disease even after proper treatment for early stage disease. Stage 4 needs more. If you are a young woman who started off with a stage 4 metastatic breast cancer diagnosis, your story will make people realize that this is not just a disease of older women. Young women deserve to live a normal lifespan. Stage 4 deserves more. Yes, together we can do this. When we each speak up, face to face and in social media, we create ripples of conversation. Together, our efforts can move the conversation dial that has been stuck on screening, mammograms, and survivorship to a full conversation about the kind of breast cancer that cuts short lifespans. Stage 4 needs more. So be present, be visible, be heard at cancer walks and in meetings at your churches or in your workplace. Together we must articulate that not all breast cancer is the same. Stage 4 needs more. Finally, we must let our doctors know that we want them to focus on helping us live better with metastatic breast cancer, including helping us with pain control right from the beginning. We want help sleeping better, and we want help to address our anxiety. Stage 4 needs more. It was Mother Teresa who said, "I alone cannot change the world, but I can cast a stone across the waters to create many ripples. Together, we must create waves, and we can and we must." Thank you. And now I would like to begin a short introduction for our next speaker in Plenary 1. While I have just encouraged you to speak individually, to tell the whole story, the Metastatic Breast Cancer Network, approximately 2 years ago, came to the realization that we need other breast cancer organizations and cancer organizations to embrace us. And so at last year's September conference in Houston, I announced that MBCN was part of conversations to establish an alliance of advocacy and cancer organizations whose mission would be to work together to address the unique challenges facing our community. On October 13th, 2013, the Metastatic Breast Cancer Alliance was announced. Today, there are 29 advocacy and breast cancer organizations that are part of the alliance, and Dr. Marc Hulbert of the Avon Foundation for Women is the leader of the alliance, and he is here to share with us a preview of the alliance's first initiative called the Metastatic Breast Cancer Landscape Analysis. Marc Hulbert is a pharmacologist by training and has extensive experience in managing medical research programs and grants administration in the voluntary health agency and patient advocacy area. He holds a faculty appointment at the New School University, and he received his undergraduate degree in biochemistry from the University of Kansas and his doctorate in pharmacology from the University of Colorado Health Science Center. He completed his training with a fellowship at New York University Medical Center, Skirball Institute for Biomolecular Medicine, and he serves, as I said, not only as head of the Alliance, but he is the executive director of the Avon Foundation Breast Cancer Crusade. Please give a warm welcome from Dr. Hulbert.
Thank you, Shirley. What a privilege to be here this morning. Can you hear me okay? Okay. It's what a privilege to be here this morning. So as Shirley mentioned, I won't bring it to the attention of the UNC faculty in the room that I am a KU Jayhawk grad, and so I won't get into the basketball dialogue, but second generation Jayhawk from Kansas. But I wanted to mention, just give you a highlight of what the Alliance has been up to. We're issuing the results of a major survey of more than 250 clinical trials in breast cancer, grants, almost 2,300 grants funding metastatic breast cancer research, and patient surveys, like some of the ones Shirley mentioned, about 8,000 metastatic breast cancer patient responses to what some of their needs are. So, but first I wanted to just ask anyone that's part of the Alliance to please stand, because the Alliance is not me. The Alliance is a group of 29 of us and lots of individuals. So Ginny, Catherine, Shirley. Sure. I know there's people from all the groups. The Celgene. They're all too bashful. Anyways, the Alliance is not just me. The Alliance is 29 organizations, but organizations are just an organization. It's made up of people that have been working very hard over the last year to understand what we can do to accelerate research around metastatic breast cancer. So the mission of the Alliance was set actually by Shirley and others starting last June of 2013. The vision is to transform and improve the lives of women and men living with metastatic disease. In last August of 2013, I was very humbled when Kara Thompson from Celgene and Shirley Mertz from the Metastatic Network and others came to me and said, Mark, would you personally lead this alliance for the first few years? Would Avon Foundation please be the administrative home of the alliance? And I immediately said yes. That was about the third week of August, and they said, great, well, thanks for saying yes. We'd like to go public on October 13th. So in 6 weeks, can you please make that happen? So thankfully, they had a mission and vision statement already in existence. And our main goals that we're starting off with for the first year and going forward, research. We want to do a better job of coordinating metastatic breast cancer research, accelerating metastatic breast cancer research, advocating and funding more of it. As Shirley mentioned, it's an underfunded area. We want to improve access to information and services and support for all of you that are living with metastatic breast cancer, all the men and women that have this disease. We want to educate the public about metastatic breast cancer. The public, as Shirley mentioned, doesn't understand that metastatic or stage 4 breast cancer is different than early stage breast cancer, that you are on constant treatment, that your treatment changes over time, that your needs and your support services that you might need change over time depending on your treatment regimen. And lastly, we want to count. We want to have a better count of people with metastatic disease. So the registries in the United States that collect cancer statistics don't count recurrent metastatic breast cancers. They only count women that are diagnosed initially at stage 4 at their initial diagnosis, which is about 7 to 10% of new cases. They don't count the up to 1/3 of women and men that will have a recurrence after their primary breast cancer. And so we're going to report on this. The report's going to be released October 13th, but I'm going to give you a little bit of a preview now. But we've already put, even though we're issuing a report, action into solving some of the gaps and roadblocks that we're seeing are already put in place. So just an example on the Count Us part, we've already been in dialogue with the National Cancer Institute, and the Alliance will be partnering with them on doing already a better job of counting the number of recurrent cases, and we have already plans in the works, just as one example. So the analysis. So what we're trying to do is identify gaps and opportunities in metastatic research. We want to understand everything from basic research to clinical trials to understanding quality of life needs, and then the epidemiology. And then we want to develop immediate action plans to move forward and fill those gaps and knock down those roadblocks. Part of the project, we talked to 75 experts, key opinion leaders, doctors, nurses, patients like all of you in this room, and asked a series of questions. What do they see as the most emergent opportunities to advance metastatic research? And just to give you a little hint, some of the early themes, again, this will be part of the larger report, but they said in clinical trials we need to have new endpoints, that just measuring shrinkage of existing metastatic tumors wasn't enough. Could we measure time from the time you had your first metastatic tumor to a recurrence of that or a spread of that to a second site? That shrinkage alone is not enough. We need to measure mets as they're evolving. that there's many molecules and targets that could prevent in preclinical models, that could prevent a metastasis from a primary or prevent secondary metastasis from the first met, but that some of those don't make it into clinical trials because the endpoints aren't there. Again, I said some of these things are already moving into action plan. On the third week of October, the FDA is holding a conference specifically about metastatic breast cancer clinical trial and new endpoints. And so I think any of you can join that online. It's an online conference. It's a whole day event. And I think immediately following that, there'll be opportunities for the public to comment and give their 2 cents about clinical trials. And so I hope the Metastatic Network will get that out to all attendees, any advocacy calls to action. We need more academic scientists like those here at UNC and others to study breast cancer. With industry, we need to involve more metastatic patients working more closely with industry. And we need to have cross-industry collaboration. And I think one of the best strengths of the Alliance is that we have 6 of the leading oncology drug and biotechnology companies, Celgene, Eisai, Genentech, Lilly, Novartis, and Pfizer, that are all part of the Alliance, and they've actually been actively involved. I've actually talked with their head of the R&D of all these organizations, and so they're engaging in many ways, and so I think that we have the ability to influence them and accelerate trials in metastatic breast cancer. And then the last thing I'll mention is from the KOL interviews is the need for tissue. So too many laboratory studies look only at the primary tumor that a woman or man had when they were diagnosed with breast cancer. Not enough research is going on looking at the metastatic tumor and comparing it to the primary tumor. And also if there's intervening bloods that have been drawn looking for circulating tumor cells or other markers that could have been in the blood between the primary and the metastatic. So that's another big need, is the need to study metastatic tissue. So the next part of the analysis, we're looking at funded grants, and I won't talk much about this. Again, stay tuned. It's going to be about, 4 more weeks, and this will be public information. We're still crunching the data and have people reviewing the report. But we've looked at 2 funded grants databases, and you can, if you're interested in metastatic research, you can go on these. These are public database. One is called the International Cancer Research Partnership, or ICRP, and the other one is called the Health Research Alliance, or HRA. But these 2 databases hold abstracts at the individual project level for medical research grants that you have funded. As U.S. taxpayers, your taxpayer dollars fund money to go to medical research at NCI and the National Institutes of Health. And if you donate to Avon or Komen or other funders like the Breast Cancer Research Foundation, then some of your donations go to medical research. And these are all housed in these 2 shared databases. And so what we found between these 2 databases was 19,000 grants relevant to breast cancer since 2000, totaling about $15 billion US. And we've done an extensive search, and we found about 2,300 projects specifically and solely focused on metastatic breast cancer. And so on October 13th, we'll be releasing the results of what do these grants tell us, and can we identify any gaps in metastatic research that we can go in and fund and advocate for and fill some of the gaps. And then clinical trials, and this is the third part that we're looking at. And I think this is exciting because it's relevant to many of you in this room. Are many of you on clinical trials? Would you raise your hand? And I know that you'll have a whole session in the next day or so that talks about clinical trials, so I won't go into a lot of detail, but I did want to give you a little flavor of what's going on that we found in our analysis. So we went to clinicaltrials.gov and breastcancertrials.org and extracted all the active trials in metastatic breast cancer. We found about 180 that were targeted therapies, and I'll describe that a little bit more, but a targeted therapy is like Herceptin for HER2-positive breast cancers, as just one example of several. Chemotherapies, we found 30 active trials, and then we found about another 30 that were specifically looking at metastatic patients that had a brain met, or a lung met, or a bone met. The targeted and chemotherapies didn't prescribe which organ the met had to be in. And so again, 180 targeted therapies. So again, this is just one example. HER2 is just one member of a larger family of receptors. They sit on the outside of cells, as you can see, sort of the orange HER2 labeled molecule there. It's a protein that sits on the outside of your cells. And in HER2-positive cancers, they have many, many copies of that protein. And so when its ligand comes around, it can stimulate the cell to grow and become dividing improperly. And so drugs that target this HER family, so Herceptin targets HER2, Tykerb is a molecule that targets HER2 and HER1. But these targeted therapies is the future. And that's, as you can see, we've made advances for HER2-positive cancers, for ER-positive cancers, and it's the future. And if you want to know more about specific what is targeted therapy, the best site I would recommend is breastcancer.org, has a great description of targeted therapies, as does actually the NCI has a really pretty good description of what targeted therapies are. And this diagram is from the National Cancer Institute. And so again, just briefly, what are the phases of trials? Again, if you want to learn more about clinical trials and what do the different phases mean, the Metastatic Breast Cancer Network has a really good description on their website, again, as does breastcancertrials.org. But a phase 1 trial is really only a safety trial. We're trying to see, is the drug safe in people? Most phase 1s only involve healthy volunteers, not even people with the disease, although that's changing a little bit in the cancer setting. And they recruit about 10 to 20 patients. Phase 1B/2 begins to look at is the dose of the drug, is it safe, and the effectiveness. And they often recruit 20 to 80 patients in that ballpark. Phase 2 trials look at safety and effectiveness. So is the drug safe and is it effective? And that's 50 to 300 patients approximately. And then phase 3 trials are randomized, and they're looking at safety and effectiveness. They're comparing it to the current standard of care and saying, is this new drug better? And so you have to get through all these phases before you can get to an FDA-approved drug that then your doctor could prescribe to you. And so what we found in our search, those 180 targeted therapies I told you about, was that there are 74 that are at the phase 1 stage, 22 at the phase 1 and 2 stage, 54 phase 2, and 17 phase 3. And Shirley mentioned Joni, who was one of the Metastatic Breast Cancer Network's members and staff members. And she passed away, sadly, since last August. But there's a quote she used to say that she wants all of you with metastatic disease to have realistic hope, that you could have things coming in the pipeline, that there's things in development. And the fact that there's 54 phase 2 clinical trials and 17 phase 3 clinical trials, all with targeted therapies, like the HER2 targeted ones I've mentioned, it's very exciting. And I think that you should have realistic hope. The 17 trials that I mentioned, they're studying PI3 kinase, another molecule that you can look at, more drugs under development for the HER2 positive cancers, CDK4/6 inhibitors, you probably have heard about those in the news recently, PARP inhibitors, HDAC inhibitors, and this is just from the 17 phase 3. Again, remember there's a huge tail of 54 phase 2s and earlier studies. So a lot of work ongoing, but still more to be done. And then lastly, and then I'll stop and take questions, we are looking at quality of life issues and the ability to get information and services and support to all of you. And so we've looked, as I mentioned, at 12 different surveys. I know this is way too small to read, but this included responses from about 8,000 people living with metastatic breast cancer, what some of their quality of life needs are. And so this will be part of this larger report that we're issuing October 13th. So stay tuned and be prepared, and we'll send it out to everyone broadly. In addition to looking at quality of life surveys from patient responses, the Alliance really took a really deep look at all of our own selves, all of our own organizations, what's on our own websites related to metastatic breast cancer, what brochures are we printing, what programs are we supporting to support patients, and we're learning how we can work closely together as Alliance members and make sure that we're getting out consistent messaging related to metastatic breast cancer, make sure that we're not duplicating too much and doing what we can to broaden the support. So I think the fact that the Metastatic Breast Cancer Network and others, like all of you, stood up and spoke and shared your voices, I wanted to just say that I think that the world is hearing it now, and I hope that you're as thrilled as I am that this alliance has formed, and I think your voices are now being heard, and I look forward to continuing to lead this alliance for the next couple of years, and hopefully we can really make a difference in metastatic breast cancer.
Okay, one question was, how can we hear your official report in October about the Metastatic Breast Cancer Alliance?
So we'll stay tuned. We're planning a few events, but I think that if we actually end up having a live press conference, I don't see why we couldn't live stream it via the web. And then I hope that, because we will have an actual printed glossy report, I hope that the Metastatic Network will email all the attendees the link to the PDF of the report.
And then a tough question to answer, but it's the right one to ask. Why has so little money been given to metastatic breast cancer research?
Yeah, a tough question, because I don't know the why. I'm relatively new to this field, but I think it was an area that scientists didn't know how to study very well. As I mentioned, most of the tumor banks and tumor registries don't collect the metastatic tissue to even study. So I think that there are things that can be done now that maybe even the technology didn't exist 5 or 10 years ago. I know metastatic tumors didn't used to be biopsied, but now that's becoming much more common practice. So I think maybe the tools weren't there, but also, frankly, I think not enough spotlights were being shined on it. But now I think academics and scientists and industry and nonprofit foundations are hearing that and moving forward more rapidly.
And I just want to add, as a non-scientist, but someone who goes to a lot of breast cancer events, what I've learned is that you have to have basic research before you can build upon that for more complex stages of the disease. And what I want to share that's so heartening to me is that when I go to conferences now, whether it's San Antonio or ASCO, and I'm not trying to drop names, but those are the places that have breast cancer discussions, it used to be years ago that it was the very last day that metastatic disease would be talked about. Maybe on the Saturday at 11 o'clock before the conference ended at 12:30. Now, issues related to metastatic progression and other issues are discussed oftentimes on the very first day. So I'm really heartened by that, and I think you should be too, but we have to keep the pressure on. Okay, maybe our last question. Oh, okay. How will the Metastatic Breast Cancer Alliance hold itself accountable for its goals and mission?
So I'll hold that question, I'll answer that. I did want to just put a plug. I wanted to thank AACR and the San Antonio Breast Cancer Conference organizers. We submitted 2 separate abstracts about the work that we're doing, and the abstract on grant research and clinical trials analysis was accepted and will be presented at San Antonio in December. And then the abstract looking at quality of life and the needs of patients was also accepted. So I really am pleased that those organizers accepted that, and we'll be able to tell the story of the Alliance and of metastatic patients. So what was that question? Sorry.
No, that was it.
What was that one?
How will it hold itself accountable? You're right, I didn't.
So how will we hold ourselves accountable? First, I think what we're doing is as a large group and in very public forums. When we get together at San Antonio and ASCO and other conferences, if any of you are attending those, please let us know and be part of our discussions. The Alliance is tending to be inclusive. Anyone that wants to join. Right now it's organizations, but we do hope that people will join us. We're trying to be as inclusive as we can, and we don't intend to be excluding anyone. So we hope through our transparent and openness that we will be accountable for ourselves.
And then the last question, why doesn't the cancer registry count people with metastatic breast cancer? Is it too expensive? I would just like to share, as a patient, I never knew that because I had early stage in 1991, and as I got into advocacy, I found out that I'm counted. I'm in the registry for having had disease in 91, but they don't know that I have metastatic breast cancer now, and the next time they would count me is when I die. So that's really very unfair, because how many of you, not that I'm important, but how many of you are living with a metastatic disease that has come after an early stage diagnosis? Well, look at that. It's almost everybody. And I know, and not to leave out people, how many have a de novo or new diagnosis of metastatic disease right out of the box? Okay. So I actually called the lady at the SEER registry one day on behalf of the Metastatic Breast Cancer Network, and I asked why. And she said it was complicated. She said, that there's a way, I guess a simple way now that doctors or hospitals report, disease incidence. That's when you get breast cancer. And it's clearer than she's died or he's died. Okay. So they assured me that they would look into this. And I have to say that one of the alliance partners, who is one of our heroes, I think, in the metastatic world, Musa Mayer, I think some of you know her. Yes, let's give her a hand. She's a great lady. She is working through the Alliance to further this dialogue and discussion with with SEER to change their practice. It is complicated because it will require hospitals to have a different way of reporting, but I think it's possible. So anything you want to add to that, Mark?
No, just that because of the Alliance, we're already working with the SEER Registry and NCI to see how we can improve that because of Musa's work. So,
Yeah.
And then before I end, I just had to say, is Catherine Crawford-Gray in the room?
Oh, yes.
So Catherine is actually the project director of the Alliance. She does all the work. I don't know why I'm up here talking, but thank you, Catherine, for everything that you've done.
Okay, could we have it? Oh, Avon, where's that? While Ginny's looking for the last question, and I do want to end on time, we have 5 minutes, but we may end a little earlier. I know just sitting there, you would not have the full impact of what Marc, I have a friend of his, so I can touch him, what Marc has done to research the metastatic breast cancer research, what research grants have been approved, what they've been about, the clinical trials. He has shared this with other people, and some people in lung cancer said, my gosh, we should do that in our disease. Because what happens is researchers don't always talk to each other when they're doing dialogue, except, of course, for like the Translational Breast Cancer Research Consortium, that they talk to each other. But so this is a phenomenal hours and hours of work, and that's why I'm so hopeful that this is going to help us. So the last question, Shirley. How much of Avon sales of go to breast cancer or research, the Avon Center?
So Avon, it's really unique. So Avon, the company, gives the foundation money to help us. We have a series of walks across the country, and they underwrite most of the costs of that, the marketing and advertising for it. They pay for all the staff. There's 12 of us, not very many for a foundation of our size at the headquarters. And so the corporation pays for all the staff of the Avon Foundation. And then separate from corporate investment, they sell cause-related products, and 100% of the net proceeds, and Avon's cause products are usually $3 or $7. They're not very expensive items. It's candles or coffee cups, and 100% of the net proceeds goes back. So Avon, the company, doesn't take any portion of that, and the Avon sales representatives, Avon ladies is what they used to be called, around the world forego their commission on all the cause-related products. And so 100% of the net comes back to the cause. It's a great organization. I'm so thrilled to be it. I didn't have any slides about Avon because it's not an Avon commercial. This is an Alliance commercial today. If you don't know anything about the Avon Foundation, I really do encourage you to talk to me. I encourage you to go to our website. We've been doing amazing work trying to understand and end disparities in breast cancer. We do amazing work making sure that every man and woman diagnosed with breast cancer can access care. We support programs for those that don't have insurance, those for low socioeconomic and other disadvantaged groups. So if you don't know about us, learn more.
Okay. Well, thank you so much, and this ends Plenary 1.